Good morning, everyone in Nepal, and good evening to everyone in Canada and UK. I would like to welcome Pediatric Palliative Care Eco Session to Nepal, and today is the second week of our session. I'm Dr. Sudhir Sapkota, and I'll be your host for today's program. Before we start today's program, I'd like to remind you of a few Zoom norms. Please mute yourself when you are not speaking. And since your name is required for attendance, please check you are attending the program with your own name instead of others' name or the mobile's name. Today, today we have Pukar Shah as the speaker, and followed by that, we'll have a case presentation by Indu sister, Indu Adhikari sister. Dr. Sunny and Saskriti will be timekeeper for today. And for today's program, the key learning points will be reviewed by Sarmila Mizar sister and collected by Sarmila Mizar sister, and it will be reviewed by Savita Panthi sister. So let's start today's program. Starting today's program, I would like to welcome Pukar Shah. He's a clinical psychologist and he has done MPhil. He currently is working in child and adolescent psychiatry department, Kanti Children Hospital. And in fact, we are very privileged to have him in our oncology ward and in our palliative care team in Children's Hospital. It will be 25 minutes for him. Over Ram Pukar Shah.
Thank you. Thank you, Dr. Sudhir. Thank you for your kind words. And it's really a great honor to present with such a distinguished guest and with the uh, talent of huge knowledge. And it's one of my learning phase. So I'm really happy to uh, be here. And thank you for all the opportunities. So happy Magi Sankranti to all the Nepalese friends and colleagues and teachers respected. And happy Magi Sankranti to all the people abroad as well. Today is 1st of March, and we celebrate Magi Sankranti by having some sweets, and it's really popular in Nepal. So happy Magi Sankranti, and let me just begin with today's presentation topic. I'll be discussing about breaking bad news. So we all might be familiar with how in palliative care and in oncology, it's one of the most challenging feature when we have to express the news about like the whenever like treatment protocols or there's something like your diagnosis is this and relapse is there, now there is nothing much, but so there are a lot of these challenges that we face. So our major agenda is how can we do that in more effective way. So major objective is to find out the method to deliver this news to our patients, family, and for us as a clinicians, how can we learn to have it in better way? So that's our main objective. Let me start with what is bad news. So we all know that bad news is something drastically or negative alter to the patient's view about his or her future. So it's simply about that it's a future changing decision or information that is passed from any individual to the next individual in a general like daily life activities. And when it comes to the medical setup, then it's about like something that is not going well in their near future. The same thing is defined by Hatfield and Tyre, suggests that losses may that takes many forms like love deaths, devastating diagnosis which shatters hope, dreams, aspirations, disability, impairment, or poor prognosis, confirming or confronting the recipient worst fears. So we all are familiar in our oncology practice so far, like how devastating it could be when we have to break the news about like it's coming to an end. Now, the principles of breaking bad news to children and adolescents. As a patient, they have a right to have accurate and true information, receive or not receive bad news, decide how much information they want and do not want, decide who should be present during the consultation, that is family members, including children or significant others. decide who should be informed about their diagnosis and what information that person should receive. So this is just a general principle on which we all tend to like start our conversation with the particular, let's say, client or the family with whom we are going to disclose the information about. So moving forward, we have this chart where I guess all of you can see, like this is a way of process actually how we deliver. So the first of all, we need to elicit what is the client's understanding. Does the person know or suspect the truth? Now there's two options as obvious, yes or no. So at the right of my side, you can see like exploring level of knowledge. Like so often when we go to oncology ward, like in our context, most of the people by the like 3 months or 4 months because of the long stay in hospital, they are able to see, oh, my WBC count is my child's WBC count is this much, so here is the problem, or RBC is problem, or they need this. So they have acquired this knowledge through sharing in among the groups. And so often like doctors or nurses doesn't even have to tell them, okay, your report has this, so you need this. They already like move on to the process and they may collect blood or something. So we just need to explore the knowledge. What are their knowledge level of knowledge? They may have past knowledge about as at the same time. Confirm news about person's place. And if they don't know the like truth or knowledge, then please give them a warning search. Break news at the person's place in manageable chunk. So we need to like really take the time and give it information in like small bits, because it's really devastating somebody to go through all this, and there's a lot of emotionality and the background which we'll be talking about how to handle that. But at the same time, to receive any information, they need to like really have the breaks. So often we find so many our clients parents, they break down into the tears, and we have to like really hold up and then first of all calm them, and then again we start it up. So once we know this informations and once we have delivered, acknowledge the immediate reaction. So that's what we do most of the time. We acknowledge, yes, it's all right to feel this way. Allow the person's time for initial shock. So we all might, even if like pandemic, for example, we might have been in such a shock like with the second wave, and it's all right. So we need to have time for ourselves to get back, gather ourselves, and let's start the working again and deal with the emotional reactions and questions. So often they have a lot of questions, even though so many times we feel like, oh, it's done from my part, but still they may have so many questions, and it's good to have their questions answered. So it's all about like dealing with the soft reactions and holding back even our emotion at the same time being a clinician. So here, when I say clinician, it means like it may be nurse, it may be psychologist, it may be social worker, or it may be doctor or senior doctor. So it could be like those team members, and offer support as appropriate. So many times like they may need like some sport, like maybe if it's still adolescents, there might be hug, or maybe just a touch, a pat of the back, just a warm to so, or if it's a parents, if we can touch them with their permission. So these are small like supporting gestures, or like allowing them to ventilate them if there is their level of stress or something that we work later on. So this is the whole model how we work in. So how can we do it? So there are 6 steps protocol for delivering bad news. So here we have this step one. First of all, we need to set up the interview. So we have to be very careful where we want to carry that interview. So we need to choose a place. It's better to have a quiet, non-disturbing room where like there's not much flow, so that it won't be disturb the rhythm, and also like we can give the full attention as we ask to provide the support and listening to them. And as we have discussed about assessing clients, like patients' perception or family members' perceptions, so they may have a lot of information. They might already know about the informations which we are going to tell them. So it's good to explore there, and also invite them like what they know and what is their knowledge and all those things. Address the emotions with empathetic responses, which is really difficult and challenging when we have to face all the parents with tearful eyes, their tears on, and it's really challenging at that moment. So, and then again, we need to summarize and provide the strategies that still what we are going to do. So there's a bit of hope for managing, hope in the sense like for their better care. So we have to use that strength. So how should I tell the bad news? So first of all, identify the correct patient and family. So often we may have like misconception, like you have like Ram is very common name in Nepal. So you don't want to miss Ram as like three people, and maybe just one people has that particular relapse or something like that. So you want to identify with the correct patient and correct family. So many times there may be like some friends might be coming over, and we may pass out the information, and they might like we do our part of job, but it's not accurate. So we need to really find out who is the right client and who is the right family, including now include significant others who have permission to be informed. Like maybe sometime we ask husband and wife, it's better to have the couple together. Sometime it's like uncle or aunt, and we ask the like keen ones to be. Or so often in our country like Nepal, we have like a problem with like one family member sitting in the hospital and next one looking for the other part, or like for example, mother will be with the child and father will be going for the work or something, or they're like bread earner for the family, or they're at the village. So many time we have to wait, like wait for the both them to come back. So it's very important for us to really find out the support system for the family and patient. Who should break the bad news? Now this is interesting. Ideally, lead consultant or senior non-consultant hospital doctor known to the patient or in whom the patient has trust. So often we have a very good rapport, like, because we all know that it's been a long stay at the hospital. So many children find interesting with so many doctors. Like I find so many times like our children are familiar with senior like Dr. Sudhir or like Dr. Bisnu. So they're like senior most over there, and they have very good rapport at the same time. Or our nursing staff has very good rapport as well. So it depends like who would be like more close, and it's better if we have somebody senior like Dr. Sudhir or Dr. Bisnu or like a nursing head. So it's good to have them, and or whom the client trusts. So ensure all the information available is accurate and relates to the correct patient. So it's very important. Like so many times we have like we may have an error like okay, printing mistake is there and your this is that, and you already tell all the information now this is not, then that's a blunder. So we need to all have our preparation beforehand. And in exceptional circumstances of death of a senior member or nursing staff may break out the news. So if there is something very urgent, like if we lose the patient, it's better that at that moment who is the senior. So there will be like this, authority power level where the people start listens to the higher authority rather than the lower ones. And then like there is probability like, and also they have a higher experience and they can handle the situation better. So it's always good to have the senior and experienced candidate in front to do these such things. In a sense, tasks of breaking bad news should not usually be given to the junior staff, as there might be a lot of challenges. It is recommended that one other member of multidisciplinary teams, such as nurse, social worker, psychologist, should be present, or social worker, doctors. So whenever the consultation is going on, if they need any support, like this multidisciplinary team can actually handle those issues and help in better way to support the patient and family. So where should I tell the bad news? So we have discussed about this. Location has to be like comfortable, confident, and private space. It's better if like patient are bed bound. It may be necessary to transfer the patients in his or her bed or suitable private room. So if possible, only with the patient permission, try to ensure that patient has support for key relatives or friends. If it's adolescents, like they want to like whom they want to be with. So it's easier if it's children below like 10 years, then we can have the family members or uncle whom they feel like want to. It is ideal if they can have a private room with comfortable chair, even height. This is very important. Like so many time we don't think about like what kind of chair or what kind of tables or furnitures we have to have. So it's better like we have a table with same height, so there won't be like power differences, and also they find like equal and respect to each other. So that gives the sense of trust, and also they give the information in the receptive way. So we'll talk about this, and we make sure that we do not turn off our mobile phones or the pages or like internet, Facebook, Instagram, or Twitter. It can be really distracting at that time. When do I tell the bad news? It's better like as early as possible with the multidisciplinary team. and that's better. So that helps or allows time for the client and the family members to prepare for like the process. What should a patient be told? The defensive answer is truth and nothing but the truth. So often we have this, what shall I tell? Oh, they might be devastating. So many times we have our own like procrastination or prediction about like this may be reaction, and I don't want to have that. And so many times we get into this mind trap. So that's where we have to reflect or take a time out and be ready that we have to tell the truth. So knowing how much information the patient wants to receive will guide you in informing them without overloading them with information. So many times it's we have to be very careful like the terms. So many times like simple like leukemia, or like let's say you have blood cancers. Now they don't understand the types of blood cancers, or like this is high, that is low. So we need to make sure like really we have to use a language that they understand. So I find it very interesting when Dr. Sudhir and Dr. Bisnu, we have been together while we were discussing the bad news. Like they use very simple Nepali language. At the same time, they use drawings to make them understand, which is very, very important. So that drawing helps both client and their family to understand, even if they are illiterate. And the language is used in such a way. So that doesn't give like overburdening, or there's not like hi-fi terms, so they understand it. It also gives patient a sense of some control over the process too. So they understand what is actually going on. And once people understand, it's better that they can process it. To ensure that patient understands, give accurate and reliable information. We don't give any false hopes. So we use the statistical methods. Okay, this is what we have, or if it's not, then this is what we have. But what are the other things? So we generally, or most of the time, we just provide truth, no false hope, or no like giving like bluffs or something like that. It is often difficult for people to take in all information during one meeting, and it may be necessary to arrange a follow-up meeting to allow the patient to come to terms with the news and ask any additional question they might need to answer. So many times it's better that we have this follow-up meeting, because so many times they may be going through all those emotionality difficulties which they may not have understood, or they may still have some questions, or they might have this cultural belief if they can do some rituals or some other stuff, they may have hope. So there will be a lot of suffering for the client and the family members at that time. So it's better that we have the follow-up again. Just let me share one experience when I say this time and room space. One of our senior, I've taken this example from Dr. Kailas. He's one of our senior most pediatrician. We worked in oncology for a long time, and he gave this example when we were having a training. Like he used to reveal this. Some of the people used to go to like he used to stay in the quarter where like Kanti Children Hospital is. So people used to often meet him like on the way, on the shop, like whenever he used to go. Once one of this client went with the report on the like market shop, and then Kailas sir somehow he said like this report is terrible. Now just imagine on the road where he was just buying vegetables, and somehow the information slipped, they went into devastation. So we don't want this those scenario. Like sometime when the client comes by rushing to you like with the report, and you just stay on the corridor or in the hospital premises and you just walk away. So that's a blunder. So it's one of, and it's very very great honor like such dignitaries sharing such experiences, so we can learn this from them. And so many times, patient with an intellectual disability or cognitive impairment or like minors may not have the right information, or they won't understand it. So we need to understand again with the non-verbal clues like the drawing that I told you, or they may not be educated as we expect to be. So we need to understand this factor as well. Now this is an interesting part where we find a lot of like your responses. So we all know that whenever there's something wrong or any information, we go with the denial. So we deny that, oh, this cannot happen. Or we go with the anger, like, how can this happen? I've done so many things. Why to my child kind of thing. We hear this every now and then, like, no, it cannot be possible, or they'll be angry. Why, how, I've done nothing. They have been eating like like 18 months and 12 months or like 24 months babies. Like what's wrong with them? And like they try to blame. and then they're helpless, misinterpreting the informations. So often they'll be having guilty agitations, and we have this cultural like carrying things of karmas and all those things. So they have a lot of like because of this and that, and they have a lot of anxiety. So we have seen a lot of mothers who like literally they beg in front of you like, please save my child, and kind of this, and it's really really harsh on those parents and us as at the same time. So these are like we have to take care of this emotionality. Now language and culture is very important again. So if there are languages difficulty, interpreters should be used. Like we in our facility, we have in our country like 123 languages spoken, so it's a terrible thing. And we have from Tarai, we have from Himalaya region, we have from Hilly, so there are a lot of languages, and we make sure that they understand. So thankfully, like we remember this case from Tarai where we are having difficulties to communicate in Maithili and Bhojpuri. So somehow I had this knowledge of Maithili and Bhojpuri, so I had like I supported the team. Similarly, so many times some of them are speaking Tamang, and so we have our staff who can speak Tamang. So we use that like passing the information. So many times we have to take care of this language difficulty, and we can use the interpreters. Or even like when we have our rotations with like foreign doctors who's coming or visiting to us. So some of them understand English, but somehow they like English, but again the English is different, you know. So even for them we have to like really make them understand so many times. So it's good that even those who are coming to learn has to understand these things. Be aware that culture, race, religious belief, and social background of the patients, and how it affects when we deliver. So it's there are a lot of homeworks to be done on this domain, and we have to always include this multicultural aspect. So how do I give information? So we have to assess the family significant understanding situations, priority. We set the meeting, and then we have to explain that what do you think, like make them understand like what do you think was going on with you when you have felt the lump? Or just open the door with some question. What have you been told about all this so far? Are you worried that this might be something serious? Like we just give the like alarming sign to them, like something is coming, so that they'll be prepared at the same time. So before you break, like we prepare the client by saying like in Nepali we say as तपाईहरुको like your reports are not good as expected. So तपाईहरुको report राम्रो आएन, and then we start. So alikati garo huna sakcha. So that means like it can be serious, or we are concerned by the test results. The test results are due back later today. I'm afraid I have bad news. So then we say like slowly we prepare the patients and the family member to move ahead. So that allows ample amount of time for us and them to be ready to listen to us. Now when we are delivering this information, it's important that we have some basic psychological counseling skills. Like empathy is one of it. It's about like feeling the other's shoes. So we need to like really have active ears to listen, identify emotions of the patients and their families, and then also like have to have like just ensure like what actually they had the information about. Like so many times because of emotionality they may like like trauma reactions that pause and you don't know anything. So we need to make sure like what did they feel like, are they feeling good, have they understood what we have been told. So we have to address the ventilation part, address their emotionality, and so the patient that you have identified both their emotion and its original. Like hearing the results of bone scan is really a major shock to you. So like we have so many times bone marrows report, and then they might already know or they might be emotionally broken down. So we have to like really listen to them what exactly like they have to tell or share, or what is their information. So in this phase, how can we handle it? Basically for anger, because so many times that we have like aggressive patients. So first of all, we need to acknowledge the anger. It's all right to be angry, because somebody who is having such a huge uh, information. So at that point of time, we need to really have the acknowledge and identify the focus. So what is their concern or anger about, and allow them to express it in an appropriate way. but we do not encourage them to like just dismiss the anger or reject focus or defense to actions or colleagues, like they may bang or like, so that's ineffective approach. So like, okay, you should not be angry kind of thing. Okay, it happens, come on, you got to be stronger or something like that. So these are not the right method. So right method is, okay, it's all right to feel anger. Please could you tell me more about what are that things that it makes you angry or you're upset about, and allow them to express. So in Thailand and all sense, again, we had all this background. So we use now language, what we have language appropriate to understand, identify the children, and give them like regular information according to what they understand. So this has to be with children and adolescents, like for above like 12 years of age, we can directly talk to them. And if it's below like 8 to 12, then again we have to use the
Yes, sir.
support and drawings.
We have
And
5 minutes.
yes, sure. Thank you. So child should be told about as soon as possible so that they may not have this anxiety, or they might not just live in that like go into the depression. So many times we find like this adolescents who has been not told, they have disturbed sleep, they have like breathing difficulties, and then we have to again like other complications are there, or then deterioration is quite faster again. So depending on the relationship, we can explore and like talk to them. Over the childs may repeatedly have so many questions, or they may have a lot of queries, and like what will happen to them. So their question has to be addressed. So we again take time to address the question. And the self-care, like I told you how challenging it could be. Like me and Isha, when we went to the oncology for like a round of couple of weeks, it was like every day when I used to go, I used to have a tea break. I told Isha, like, says there, like I need a cup of tea. I cannot, like, I was having a heavy head even when I was just standing on the round. So you can imagine the amount of emotionality burden that I may carry when I'm dealing with such devastating news. So it's very important for us to take care of our self-care as a clinician or nurse or as a social worker, psychologist or doctors. So we need to take like be aware of our feelings, talk to the peers, like other support staff, and take a break if needed. Do some like take a break of 1 or 2 days, have some refreshment. So follow your hobbies and passions, passion about yourself, or take a time out. So that will help you. Generally, in like around for me, tea would be very good, and luckily we have tea served after the round. That's great. So when there is a death, what shall we do? So when there is a death and there is a lot of anxieties, worries, so it's better that uh, again the multidisciplinary team like shares the news. And so often when it has to be told on online these days or telephone, then make sure the staff and the right person is chosen, and you are talking to like people who is 18 years and above, who is a recipient of the call, and the right person at the same time. It's better like the information should be delivered with this proper care and sensitivity. You can't be like full of anxiety, or you call immediately because it's really very sensitive issues. So we take care, and we take like the uppermost like senior staff who is present during that scenario, calls to the family members, make sure that the family members is the correct, and the member is above 18 years and they have understood what information is delivered. Now, just to have the take home message, I have just used this ABCD mimic for breaking bad news. So, first of all, just to recap and take home messages: advanced preparation, arrange for adequate time, privacy, no interruption, review clinical information, mental rehearse, identify word or phrase to use and avoid, prepare yourself emotionally. So, that's about like preparation. Build up a therapeutic environment or relationship. Determine what and how the patient wants to know. Have family for support person. Introduce yourself to everyone. Warn the patient that bad news is coming. Use a touch when appropriate. Schedule follow-up appointments. So that's about like therapeutic relationship. Communicate well. It's very important that we have good communication skill. Ask what the patient or family already knows. Be frank but compassionate, compassionate. Avoid if avoid medical jargons or some terminology. Allow for silence and tears. Proceed for patient place. Have the patient describe his or her feeling or the family members. Repeat the news and informations. Allow time to questions. Answer the questions. Write down and provide written information. Conclude visit with summary and follow up. deal with patient and family reactions, assess and respond to the family and family emotions, which we have talked already, be empathetic, do not argue or criticize colleagues. This is very powerful line again. So often we can't blame or because of this and that. You came here delayed. Why were you taking so much time? You should have come here first. We don't do such things. Encourage and validate emotions, explore what news means to the patient, offer realistic hope according to patient's goal, use interdisciplinary resources, whatever resources we have, take care of your needs, and also involve the house staff and office or the hospital personnel, that same information is carried to everybody and there is equal amount of response or time given to the client. So thank you very much for listening to me. I hope I made it on time.
Thank you, Pukar sir, for this wonderful presentation. Yeah, definitely you have highlighted the spikes model, which is used all over the world, and your focus on to give the information to the patient, how receptive the patients are. That is very, very crucial, and the sitting arrangement is also very vital for breaking the bad news. So we'll take the questions at the end of this session. In the meantime, you can put your questions in the chat so that Ram Pukarsa and the other faculties can answer your questions. In the meantime, uh, we shall move forward with the case presentation. And for case presentation, we have Indu Adhikari for today from Kanti Children's Hospital. She is the hospital nursing supervisor in the pediatric hematology oncology unit, and she has a vast experience working in the pediatric oncology ward as well as in palliative care. And she is also the member of the Nepalese Association of Palliative Care. Over to you, Indu sister.
Thank you, Dr. Sudhir and team. Good morning, everyone. I am Indu Adhikari, Hospital Nursing Supervisor of Kanti Children's Hospital of Oncology Ward. Today, I am here to present a case of neuroblastoma. So, let me start with the key question for case presentation. The key questions are breaking bad news or counseling to the child as well as parents. Use multidisciplinary approach during the treatment and breaking bad news or counseling. Third one is psychological counseling for the child and parents. Patient details. Age of patient is 9 years and gender female. Diagnosis, refractory neuroblastoma stage 4, and date of admission was July 18, 2019. Treatment and significant investigation. Hemoglobin 5.6 gram per DL and platelets count 10,000 per mmq and WBC count 1100 per mmq. USC abdomen was normal at that time, and treatment adapted from the rapid Kozak chemotherapy and surgery. Latest treatment was supportive and palliative care was provided, such as antibiotics, painkillers, antiemetic, stool softener were given. And holistic assessment and symptoms including relevant treatments, paleness of body or patchy and purpura in the skin. So transfusion of packed red blood cells and platelets concentration. Next, weakness and fatigue, increased sweating, severe leg pains as well as back pain. So tablet paracetamol 500 mg QID and injection morphine 5 mg for hourly was given at the time. And severe headache, so we provided mannitol, and nausea and vomiting, so we provided injection Ondem syrup, domperidone, and injection metoclopramide. And mucositis developed at that time, so betadine gargle was given and candid mouth paint and delta gel was applied. Psychological and family concerns at that time, since the child was refractory stage 4 with progressive disease, we We provided counseling or breaking bad news to the parents so they were worried about the child's condition, but at the same time, they were still hopeful. And child physical symptoms were also adding more grief to the family, and mothers usually was crying after the round. So further psychological counseling was done and supportive treatment was provided to the child. Now, they are concerned about how to manage complication and facing the challenges. Continue. The family was also facing financial problem because her father business completely stopped or closed. They have already taken loan for child's treatment and permanently they live in the hospital, but at the time of treatment, they live in the rented room nearby the hospital, where older siblings used to live in the hostel because they didn't have any caretaker at home. Spiritual concerns, family has faith on God, Hindu by religion, and for the condition of the child, they are blaming their own fate, and sometimes they consulted traditional healers such as Dhani Sankiri in Nepali. Communication pattern, the child was worried about leg pains, headache, and painful procedure that is carried out in the ward, and her parents are more worried about her condition. Parents were all known about diagnosis and its prognosis, but were hopeful for recovery, and the parents didn't discuss the prognosis with the child, thinking that it will make the sad to the child. Collaboration and parentship. Collaboration with Bhutan municipality was done to receive government's insurance. Daily dietitian visit to oversee her nutritional status, such as we provided nasogastric feeding and IV infusion at that time. And psychological counseling was done for interaction between child and parents. Arrangement was done to financial help, and play therapy was given to mind diversion of the patient. Summary of the case: a 9-year-old female child with refractory neuroblastoma who has developed mucositis, severe leg pain, back pain, vomiting, headache, and fatigue. At the later phase, so palliative care started and involvement of the family aspect of care was done. And family facing psychological and financial problem also. Question for this presentation. One is breaking bad news or counseling in progressive disease to the child as well as parents. Can this situation be handled smoothly? And next, use multidisciplinary approach during the treatment and breaking bad news or counseling. What is could have been done? And psychological counseling for the child and parents, it is effective. Thank you very much.
Thank you, sister. Thank you for the case. So basically, it's a 9-year-old female who has had refractory neuroblastoma. They had gone to their own home place once there was treatment failure. And after a gap of around 4 to 6 months, there was progressive progression of the disease and associated with low counts and other symptoms. So even at that time, when the prognosis had been explained to the parents, they were reluctant to accept that there is poor prognosis, and still they had some bit of hope that the child would recover instead of repeated counseling that the prognosis was very poor. So anyone from the faculties, what else could have been done in this case? Any thoughts on the case? Kamara, can you add few points?
Thank you. That was a very, very well done presentation. And I think speaks to the fact that many, many parents are hesitant to talk to their children. I think one of the places that we should start as clinicians is to be curious with the family about why they're scared or hesitant to talk to talk to their child. So I would ask parents, tell me what you worry about to share the news of your child. Or I might say, what do you think that's happening to her body? How does she make sense of being in hospital and having pain? And often parents don't realize that by not talking to them, they're making them more isolated. And so being curious and starting there can help you educate the parents and help them be able to share the very difficult news. Thank you.
Thank you, Kamra. And Pukar, back to you. Can you explain how to handle the situation smoothly when in spite of repeated counseling, the parents are not able to accept the fact that the prognosis is poor in case of their child?
Thank you, Dr. Sudev, for this question, and this is very relevant. So often that's where this handling this emotionality of parents. So
Just to interrupt you, I think you have seen this child.
yeah,
You are there in the palliative room when. Okay, please go on.
yeah. So basically, when this that's a denial phase, the first response that comes with the emotionality. So many times we need to like really give ample amount of time and make sure like we understand their perspective. So they may have this very high emotionality, like this mothers generally, now this cannot happen to my like child, and how did this happen, so this kind. So we need to be really receptive and just listening to them, what is actually like their understanding about this. So again, when they are in this denial phase, it takes time for them to move into that phase of anger and then acceptance. So we have this like just stages of five stages of grief, where they go with the denial, they go with like anger, then bargaining, and then depression, and then they accept, and then they recover. So we actually need to have time, but we make sure that we are available for them, and we communicate to them more often. So we make sure that they have right amount of information. It's just about like just acknowledging them, their emotionality. It's all right to feel in that way, but also making sure that we have to move ahead with other procedures. So in such cases, I feel, in my personal view, like just to be present for them, just tell them that we all are there whenever they need for any kind of help or support, and we make sure that their questions are answers, and it's all right to have the emotions and feeling that they have during this phase.
Okay, thank you, Rampukar sir. Do we have Isha with us?
I'm
Yes,
here.
Dr. Sunil.
Uh, would you like? So there are the question about how to explain the adolescent about the disease. Okay, we can counsel the parents, but how to explain the adolescents about their disease status? Can you
Yeah.
make few points about that? And is there any age limit in our law that such adolescents should be informed about their disease, something like that?
I don't know if there is a law, but an adolescent who knows, who can understand the rounds, what's going on, should be informed. Age appropriate information should be given to all children as well as adolescents. It's important that you tell them what's going on, because later they'll stop having faith in you or the parents.
So how do you? What are
So with younger children, you can just tell them the name, simple facts like, okay, it's not contagious. The name of your disease is so and so. In this, so and so is going to happen. So they're prepared a little. Okay, you're going to have to take medicines every day for this much time. You're going to stay in the hospital. If they're worried about school or academics, you're going to tell them what's going to happen with school, whether they've spoken to the school authority or something that's relevant for the child. Whenever you talk to a child, you have to always ask them what they already know, because they would have some information, but they're usually not given all the information. So you have to understand what the child knows and then take on from them. From that, if they have any misunderstanding or something, you have to clarify. Adolescents, on the other hand, understand a little more. Very often, whatever's happening in the round, what you're telling them, they usually have some idea about it. With adolescents, also the same thing. You initially ask them what they know, and then you build on it. Like next session, I'm going to talk about how to explain death to them, how to explain different things to them, because they don't already understand what's happening. But for now, I remember when I was dealing with one of the patients, she was refusing to take medicine, and it was getting very hard for the department to ensure that she takes her medicine. So at that time, she was what? She was around 10 years old or something, and she wouldn't take her medicine. And her reason was good, that it makes her feel sick. So she was refusing to take medicine. It was very hard for the department to ensure her medicine intake. At that time, I told her that the medicines are helping you. What's in your body? She knew that there was something wrong with her blood. So I said that there are bad particles in your blood. So if you don't take the medicine, then the bad particles become active. However, if you take the medicines, they go off to sleep and they'll wake up in 24 hours. So again, and next day you have to take medicine. So something that the child understands. After that, we didn't have problem with her taking medicine. So you have to use the language that the child understands. And of course, the children know that they are sick. Sometimes children are afraid. Supposing we keep them in isolation room, everybody in the world, all the children are talking that in that room somebody died. And the child himself is afraid. Am I going to die because I'm in this room? And usually when the person goes to that room, it is serious. So, things like this, you have to keep small, small things. And even when situation is bad, parents, by the time they are there, they already know that it's going to be bad, because in the initial case discussion with initial interview, we tell them this much percent for survival, this much percent for cure. So all this is already done. And then their treatment is prolonging. It's getting longer and longer. So somewhere deep inside, over the months, the parents know that it's going bad. However, what we usually don't do is we don't ask the question the child has. Parents, we told them what's going to happen. Very often we miss out telling the child what's going on or giving the child opportunities. Sometimes the child asks the parents and the parents don't know what to say, so they tell us that the child is having some this and this question. So we're going to talk about explaining everything to the child, what's going on, what happens, and everything later in the language that child understands. So I think it's coming. I think Rampukar made it very clear. And also the last thing that's important is, however difficult it is going to be difficult for you, but we're going to be there for you. Making them understand that is very difficult. We're going to make everything as easy as we can. And however difficult it is, we're going to be there for you. We're going to see you every day. Emphasizing on things like this, it's very important for the patient and the caretakers. Thank you, Dr.
Yeah,
Sudesh.
yeah, thank you, Isha, for elaborating on that. Definitely, what one point that she has mentioned about stigmatization of the beds, like in our ward also, sometimes there are few beds in which we usually keep the sick children. That's because they have got cubicles and they get more facilities. But once the child has been shifted to those beds, they feel that okay, now I'm not going to improve because I've been shifted to this bed. So we need to uh, avoid such stigmatization also. Now, the floor is open for question. Anyone from the participants would like to raise the question, you can unmute yourself and ask the question to the speakers, or any one of the faculties would be happy to answer you.
Hi, hi, I'm Dr. Susma. My question is for Ram Pukar. Thank you for such a elaborative presentation. And my question is very difficult to break the bad news in adolescent as we faced in our day-to-day practice. Is there any role of parents breaking the bad news in case of adolescent?
Yeah, that's clearly there, ma'am, and thank you for the question. Uh, it's really difficult for adolescents, as because as Isa has already mentioned, they have a better understanding, their cognitive abilities are higher, and thing is, it's that's why we say like multidisciplinary aspect when we are breaking the bad news. So when we are talking to adolescents, if their parents are around, that will be more helpful. But again, we should not be having like just breaking bad news to the parents, but not to the adolescents. That's where Isha was mentioning, because they already have this idea about like what is going on. I'll just give you one example. One of these 14 years old from, I guess it's from the western part of Nepal. He came here and he was like, he lost his weight drastically in a couple of weeks. His report was still pending, but he had somehow had this idea like he's not gonna survive. He didn't even speak with us. Like, I guess Isa also remembers this case. And we started with the drawing. So he was very good at drawing. After a couple of drawing, we were able to break him, and he spoke like I'm going to die. Like his first worry was like he was going to die. Like I'm just like, but we don't have the report yet. But says I have heard this thing, and people are saying now I've been suffering and all these things. Yes, of course he's suffering, but that doesn't mean that he's going to die. So that small bit of conversation actually was like breaking the ice. So many times when the parents are talking like, okay, now we don't have any hope, we don't have money, because they already have this information, this will be this much cost and everything. So we need to take care of this information sharing. So they have a lot of information. That's why assessing the knowledge that the client has when it's adolescence is very important. What actually they know, what are their perceptions, and that's where the truth comes a handful. So we have reports and we understand, we have better ideas since we are the like expert in the place. And when we involve parents, then this like miscommunication, when they communicate to the parent, like they communicate to the child, like so often we find parents leaving the treatment because they cannot support to their child. So which is more like what we say, it's like it's more devastating than anything, just because they don't understand the protocol, or so many times they just give up. So we make sure like what is actually protocols following ahead, and they are like in the same pace as we all are. So of course it's challenging, but we make sure like we understand with the cultural aspect, with the language aspect and the education level, and we make sure the family also understands in case of adolescents. So there are information, so they're not like stigmatization or burden on them.
Thank
I
you.
hope I answered.
Thank you, Ram Pukar sir. Any other questions?
Yeah, could I just mention one more thing?
Yeah,
Often,
sure.
like, we know, we read about it. You should tell the adolescents what's going on in, a language they understand. But very often, parents don't want us to tell anything to the child. So we have to respect the parents' position that they don't want to inform the child. However, after some time, the child starts asking questions.
Yeah.
Then they come and tell us again, okay, my child is asking this. We haven't told them. What should we do? Then we talk to them as to what they should do, what they should say, or we share with them what we're going to tell the child. Something that's going to be helpful, as well as something that's true. And so it's very difficult. We can't tell them everything because the parents usually don't want us to, but we can't tell them nothing. So you have to, balance out what should be told. You can discuss with the parents if they tell you particularly don't tell anything to the adolescent or something like that. Thank you.
Yeah, thank you, Isha. And I think I'll take the last question to Kamara. Very often it happens that the children will feel, this is the question from Angela Gimire, they will feel the guilt of ruining the financial status of their family when they are ill. And this has happened to us and one of the children who had refractory case, and we're planning still for further treatment, and the child said, no, I'm going to die, and there it's going to be a financial hardship, so save the money and you should teach my older brother for the younger brother, and save the money for the younger brother, don't invest in further treatment because anyhow I'm going to die. So how do you tackle such situation?
Wow, I mean that's very heavy and hard to manage. I think what I would say is first really listen to the child. When a child shares something like that with one of the caregivers, it means they trust you. They're sharing something very hard to talk about. So our job as the clinician is to listen and to not try and fix it right away, but to really listen Say more about that. Tell me what your mom and dad think. Why do you think this way? And to really explore that, because I think often we want to jump to reassurance, and that's not going to be helpful to the child. We have to really hear them. If we do a really good job listening, children are extremely resilient. And if we say, it seems like you feel really bad that your family doesn't have enough money and that your treatment costs money. And the child themselves actually might come to the realization that they're very loved and that the reason their parents chose to use the money is because they want him to get better and they want him to be well and they love him. So often children can come to that themselves. And sometimes they ask that question because they want to be reassured, but first listen and hear that. And I think so much of the work we do in palliative care is that we can't fix everything. We have to actually be present to the sadness and the reality that the family is in worse financial shape because of the illness. That is a truth in there. So how do we sit with that and be with that person so they don't feel so alone in this sadness? Thank you.
Thank you, Kamra. So I think this brings us to the end of today's session. Any final thoughts from any faculties?
Thank you, Ram Pukar and both the sisters who have presented the case. Very nice. And I think today's little call, maybe chat is not that active as we expected. And thank you, very good input from Kamara and all the participants, and Isha in between very nicely elaborate. I think Rampukar and Hindi sister, they were doing great. For all the participants to be active in maybe in chat when you have any questions, and maybe you have to come up if you have any queries so that we can answer your queries if any. Thank you all.
Thank you, Dr. Krishna. So this brings us to the end of today's session. Hope to see you all in the next session next Thursday. Okay. Stay safe. Stay warm.
Thank you.
Stay warm.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
See you next week.